All right, let's get into wide regular tachycardias now, another in our series of the tachycardia lessons. And so what rhythms could be wide and regular? So V-TACH, 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 and then something that wants to look like V-TACH. Anything that was a narrow regular tachycardia coupled with something that makes a wide QRS could then become a wide regular tachycardia. So if you think back to the narrow regular tachycardias, we had sinus tach, we had SVT, we had atrial flutter at 2-to-1. And if you add aberrant conduction or you add a sodium channel issue to one of those regular narrow tachycardias, you can get a wide regular tachycardia. So let's dig into this a little bit. Any unstable regular tachycardia, we're going to synchronize cardiovert at 100 joules. So you should just know that. It should be able to walk up to you in Walmart at 3 in the morning and I say, hey, unstable regular tachycardia, what do you do? And you should say sync cardiovert at 100 joules. Pretty straightforward. And so we don't mess around with anything else. We don't try anything else. We just get it done. And so 100 joules synchronized cardiovert if your patient is unstable. If they're not unstable yet, then we're going to look further at what is the cause here. So let's remember that aberrant conduction or aberrant conduction, depending on how you want to say it and however you try to spell it, has two possible things. One is a bundle branch block, and that's very common. The other is an accessory pathway, also known as a bypass track or pre-excitation situation or pre-excitation syndrome. I think we use accessory pathway a lot in our lessons and our teaching. And bypass track makes a lot of sense to me because that's really what it is. But just remember that anything that is narrow and regular that has aberrant conduction can then become wide and regular. What's this about sodium channels? Well, hyperkalemia can cause a wide QRS by basically poisoning the sodium channel, have it not working right. And then there can be some toxins like a tricyclic antidepressant overdose can also widen that QRS by impacting that sodium channel and basically making the two ventricles not contract at exactly the same time, thus giving you that wide QRS. Remember that the TCAs that are out there these days are typically not used for depression, used for other things. Amitriptyline is a fairly common sleeper, also used as a migraine prophylaxis in some patients, and nortriptyline can have some of the same things and can be used for other reasons. So if it's a triptyline, it's a TCA. If it's a TCA and they overdose on it, it can create a wide QRS, and that could be a wide regular tachycardia, and that's where you come in to finding it. So most of the time, your wide regular tachycardia is V-TACH. And if you treat them all like they're V-TACH, it's safe, and we're going to be fine. So how would you treat the V-TACH? Well, here's the deal. Adenosine is not a bad option in the specific special case where the wide regular rhythm is monomorphic and the patient is not unstable yet. Remember, regular versus irregular is one thing. Monomorphic versus polymorphic is a totally different thing. A rhythm can be polymorphic and regular. In the case where you have a V-TACH, a wide regular tachycardia that is monomorphic and they're not unstable yet, adenosine's a totally appropriate and a pretty smart choice. It's fast to give, it starts, it works, it's gone. And the deal here is that a small number of actual, real, confirmed V-TACHs will respond to adenosine. I don't know the percentage, but it's small. It's less than 10% for sure. 4, 5, 6%, something like that. So there's a chance it'll work even if it is V-TACH. And then when you consider that a SVT with a bundle branch block or an SVT with an accessory pathway could be a wide regular tachycardia, and adenosine treats SVT just fine, it does make some sense to consider that. So again, we're talking wide and regular and monomorphic, and your patient's not unstable yet. Otherwise, you'd be cardioverting. But he's not unstable yet, then adenosine makes some sense. What else? Well, amio. Amio is the pretty much standard thing everybody should come up with. And so If the patient has a wide regular tachycardia that is polymorphic, then you don't have any option to use adenosine, and you are stuck with amio. Again, it takes a while to give, it takes a while to act, it's got a very long half-life, and it may also work. So even if this turns out to be an SVT with aberrant conduction, it may also work as well. So we talk about in lab, and we work with you and have you demonstrate to us the plumbing and logistics and math and how you're going to draw up and give amio in this situation. So then differentiating V-TACH from SVT. So differentiation of V-TACH from SVT with aberrant conduction. There are some folks out there that have come up with some rules, again in quotes, and possible ways to differentiate the two. We don't think it's unimportant. We just don't believe there's a rule that's good enough for us to use yet. So it doesn't really matter which it is. We're going to try adenosine first if it's monomorphic. If it's polymorphic, we're going to go right to amio. And so it's not that we've dumbed it down and we don't care. It's that it's not really possible to tell with enough sensitivity and specificity for us to say, yes, this is the rule. So as soon as somebody comes up with a way that we can decide whether it's V-TACH or SVT with aberrancy, then we'll teach it and we'll learn it and we'll decide it and we'll go in that direction. But I think the direction we would end up going is probably the same thing. If it's monomorphic, we're going to try adenosine. If it's polymorphic, we're going to use amio. And if it's monomorphic and we try adenosine and it doesn't work, we're going to use amio. So it may be somewhat of an academic discussion, but we wanted you to know that there are some rules out there that some folks are professing to be pretty good, and it's our judgment with our program that they just aren't good enough yet. So wide regular tachycardia, if it's unstable, sync cardiovert at 100. If it's not unstable yet and monomorphic, let's try adenosine. If it's not unstable yet and it's polymorphic, then we cannot try adenosine. We must move on to amio. The end.